Good morning, I'm Erica Mallery-Blythe. I'm going to be speaking on electromagnetic hypersensitivity. Is it all in the head? Is the burning question that is of increasing public health importance as ambient RFR levels rise. Thank you so much for this important conference from the Australasian Radiation Protection Society. My declarations are as below. So I'll briefly point out a recent ICBE publication, the public health significance of EHS, some research inadequacies, a little on litigation, and the requirement for biological safety limits. So this important paper from International Commission on the Biological Effects of Electromagnetic Fields was put out in 2022, and we've also published a fact sheet which distills this down into very digestible smaller segments of the primary 14 points of invalid assumptions that underlie the current ICNIRP exposure limits. I'm going to speak only on this one, assumption number 8, which pertains to the differences in human sensitivity levels. So ICNIRP pointed out quite rightly in 2002 variations in tolerance. They cited pertaining to children, the elderly and chronically ill, and questioned if they might need separate guidelines to safely encompass those groups, and anticipated failure with concomitant exposures, for example, to synergistic toxicants, because we can see that radio frequency can behave as a co-carcinogen, for example. And also failure where perhaps there were underlying health complaints elevating sensitivity levels. But unfortunately, they abandoned these very important points, and you can see here in their fact sheet in 2020 that restrictions have not been set to separately account for those with elevated sensitivity after all. What is electromagnetic hypersensitivity exactly? Well, if I had to put it in one sentence, it's acute symptoms attributed to non-ionizing radiation exposure, classically symptoms such as headaches or tinnitus, palpitations, sleep disturbance. Those are some of the classic core symptoms. And we can't marginalize this because figures from Europe suggest that somewhere between 3 and 10% of people are affected. There's a wide prevalence. I think that's partly because it depends whether we're looking at mild, moderate or severe. This is a classic spectrum type effect. In Australia, similar figures could lead to up to 2.7 million people currently reporting these issues. And they report symptoms from common household devices like these pulse-modulated radio frequency emitting devices, but also from household devices using ELF, extremely low frequencies also. So multiple portions of the non-ionizing radiation spectrum. And the WHO noted this issue in 2005, this from their landing page. I'll enlarge. They point out that EHS comprises mainly central nervous system symptoms, including rashes, very objective sign. And they say here, whatever its cause, EHS is a real and sometimes disabling problem for the affected persons. Their EMF exposure is generally several orders of magnitude under the limits of internationally accepted standards. But why this question about causality? Well, because groups such as ICNIRP have postulated perhaps this is all in the head, caused by a nocebo response or symptoms created by fear, if you like, a psychological negative expectation. But is it really plausible that all these people, this high percentage of the population, or in multiple countries, are complaining of symptoms from their new best friend, the mobile phone or Wi-Fi router? I would suggest it's really not plausible, but let's look more scientifically. Temporality is the only Bradford Hill criterion which is essential. If A is to cause B, A must of course precede B. And this leaves us with a dilemma because the majority of this group actually were not concerned about negative health effects from these devices. In fact, many of them had no awareness at all that it was even possible. Now, those who claim EHS is not caused by EMF rely on two basic principles. One, that there is no such thing as low intensity, so-called non-thermal effects, that those are not possible. And secondly, they rely on the outcome of EMF provocation studies. So let's look at those in turn. Can EMF exposures of these everyday natures cause biological effects below these ICNIRP limits? The simple answer is yes, they absolutely can. On the left here, you'll see biological effects such as oxidative stress. This was found in 95% of the literature looking at it. We've cited here 124 out of 131 studies where oxidative stress was a factor shown. You can find references for that in our ICBE publication that I referenced at the start. And then on the right here, let's look just at neurological effects, which are obviously extremely relevant in EHS, and 244 out of 336 studies cited by Henry-Lai as part of the Bioinitiative report. Of course, this literature extends also into the animal kingdom, so we can't be putting those down to a psychological response. And thank you to Deborah Davis and colleagues for this important paper looking at vulnerabilities of children, some of whom may also have the additional vulnerability of VHS, and showing that reactive oxygen species as are generated through oxidative stress can have cascading effects. For example, cited here, breaking down important barriers like the blood-testis barrier or the blood-brain barrier. So we really need to release our attachment to this outdated dogma that there's no such thing as low intensity effects below tissue heating. There are, of course, these effects, and they're well documented. Let's move on to EMF provocation studies. So what are these? Well, this was an attempt to look more closely at the relationship between EMF exposure and symptoms in a laboratory type setting. But the problem is this literature base has enormous methodological fatal flaws in fact, nearly all of the studies. And these stem right from selection through to design and the experiment itself, really basic errors. There's a fundamental lack of understanding of EHS in the clinical terms of it, the characteristics. So they've treated this as though it was a response like seeing a light switch turn on and off, a light coming on and off. It's not a time-locked response. It's akin to many other types of sensitivity, food sensitivity being a classic example, where there's a huge heterogeneity of response and massive variation both between individuals and within an individual in terms of the onset and offset of their reaction, which does not lend itself to this type of very short window test. In addition to that, there have been other very basic failures, often insufficient phase reversals or observations to have a conclusion. And in the sham condition, where, of course, if you were testing, for example, gluten allergy, you wouldn't give a little bit of gluten and say, well, that's the sham condition. But nonetheless, that's what's happened in many of these studies, is actually there's been some anthropogenic radiation around during the sham condition, which is, of course, absolutely prohibited in these kinds of studies, or should be. Now, systematic reviews have nonetheless gathered these together and tried to draw conclusions from them. But the problem is those systematic reviews suffer exactly the same problem. They have clearly lacked a clinical understanding of the characteristics of EHS. And as a result of this, they've not recognised the adequate study design or the appropriate guidelines for that, and used inadequate ROB tools and inappropriate tier ratings. They failed to recognise fatal flaws in often all of the literature base they're analysing, and inappropriately tried to perform meta-analysis, which is, of course, not possible when your primary core literature base is in itself invalid. And thank you to my colleagues at ICBE-EMF, some very credible and experienced authors here who have scrutinised one of the other systematic reviews looking at longer term effects, and pointed out that they call for a retraction on the basis that the body of evidence was not adequate to either support or refute the current safety exposure limits due to a small number and very poor quality of the primary studies. So coming back to the nocebo explanation, it just doesn't hold water. And I'll quickly summarise some of the reasons why. Many of these people are technophiles. They actually have continued to try to use these emitting gadgets despite their symptoms. That is totally inconsistent with the nocebo response. And actually, despite the appalling methodology and very heavy bias towards the null in the EMF provocation study literature, nonetheless, some individuals have actually demonstrated the reaction under double-blinded conditions, which of course excludes psychological processes as possible in those cases. In addition, both animal and plant studies have demonstrated EMF effects, in some animal studies actually showing avoidance reactions, and biological mechanisms that could be relevant here have been very, very well documented, such as oxidative stress. So these two principles neither of them, unfortunately, can undermine the fact that the testimonies of this ever increasing group of very credible individuals who generally have no history of mental illness of any kind. And it's no surprise that we see some groups, and thank you to the Europa EMF group, who have therefore constructed guidelines for the prevention, diagnosis and treatment of EMF-related health disorders, including EHS, but not limited to that. They're looking also at some of the chronic health outcomes, which are equally important. So ICNRP, this is up to date, 2020, have actually pointed out themselves that it's not always easy to draw a clear distinction between biological and adverse health effects, and indeed that this can vary depending on individual susceptibility. Absolutely the case. And in fact, we know categorically that it starts with biological damage and moves through acute illness into chronic illness. And if these stages aren't managed, that is the flow. And of course, that biomarkers could be available and changed throughout that process. And that is a very, very important area of research where we should be focused, because we want to pick up the biological damage. We do not want this to progress to acute illness. This is our most important area for preventative health care. Unfortunately, exactly the opposite is what has happened when it comes to exposure guideline setting. And the groups setting the guidelines have said, we're going to compartmentalize these completely separately into biological effects in one basket and health damages in the other. You absolutely cannot do that. That's not how medicine works. And they've disregarded biological damages, and they've tried to draw this line in the sand as if it's a black and white equation. And if you were forced to draw such a line, you would not draw it here. They've pointed out that tingling sensations, light flickering, and microwave hearing, they're calling these perceptions. These are health effects. They're calling them perceptions. They've said they can sometimes lead to discomfort and annoyance. And the exposure circumstances under which that platform arises will vary between individuals. It certainly will vary, but in reality, these are important health effects that signify substantial biological disruption. People with EHS do not experience merely discomfort. They can actually experience severe pain and broad-ranging disabling symptoms, as noted by the WHO in 2005. So it's not a surprise we're seeing global successful legal actions for accommodations for people who are actually disabled by their severe EHS symptoms. And in some cases, those are mandating low EMF environments. I've already mentioned that animal and plant studies are showing effects that are relevant here. And I would draw your attention to a 3-part series on flora and fauna. And of course, these reactions cannot be sidelined as psychological. EHS, coming back to our original question, is it all in the head? Whilst there are many neurological symptoms, absolutely this is not a psychological condition. It's a physical response which needs urgent attention. What can we do? Remove, replace, reduce using very straightforward techniques. And this must be done as an emergency. And I want to thank those who constructed this important document as part of the EESC, who've called for reinforcement of the independence of bodies setting limits, binding, safeguarding legislation to reduce electromagnetic radiation, and recognising RF exposures as a cause of functional disability and environmental illness. We have reached a crisis point. We're seeing children that can no longer safely go to school and adults who can't access their places of work. Equally, in both areas, we're seeing people who can no longer even access their own home safely, let alone a hospital bed, even when they can be experiencing life-threatening illness. Thank you to my colleagues at International Commission on Biological Effects of Electromagnetic Fields for pointing out that this is a humanitarian crisis which needs an urgent response. So key points moving forward. I'd like to just point out that this is a consent issue actually at the very heart of it, even for people who do not have any elevated sensitivity levels and are on some level unaware. Everyone should have the right to avoid exposure if they would like to. EHS is of major public health importance and it's unaccounted for in the current safety limits. Management relies on avoidance of anthropogenic non-ionizing radiation, and engineering substitution and reduction should be implemented. Public information campaigns need to be initiated, and low EMR zones must be constructed in hospitals and the general public as an emergency. Thank you so much for listening. Thank you to my colleagues at ORSA, and thank you so much to my colleagues at ICBE-EMF. Thank you for listening.